sedation, then usually right away doesn't produce any problem or significant problem. But 20 to 30 years later, this patient is going to come with the problem with the valve, usually in the form of the aortic or mitral stenosis, most commonly mitral and then aortic, and then you're going to have the pulmonary and tricuspid. So those are least common, but and 20% you may see both, mitral and aortic stenosis together. So about the acute right away, the only problem sometimes can happen is myocarditis. In the small percentage, actually, the patient can develop the heart failure right away. But most of the time, as I said, there's no problem right away. The problem happened years after, and it's going to be in the form of the valve problem, the stenosis, or sometimes insufficiency, or both. So they ask you about the pathologic feature of these, myocarditis in active rheumatic fever. When you look at it, actually you have a collection of these histiocyte and giant cells. So its reality is a type of granuloma. We call this Ashcroft body, composed of these Ashcroft cells, which is a histiocyte and Ashcroft giant cell, and you can see some lymphocytes. So it's really, this is what you see associated with this myocarditis and dry away in acute rheumatic fever. So this is something they may ask you in the exam because of the name, and these are buzzwords. Now, what's going to happen 20 years later? You're going to have an aortic or mitral valve involvement. In this case, you can see severe mitral valve stenosis. You can see a very, very dilated left atrium. And every time you're dealing with the dilated left atrium, you have to think about two possibilities. Every time there's a dilatation, same way as we talked about in the myocardial infarction in the ventricle, you get, dilatation, you may get these thrombus, mural thrombus here. So that's one problem. Another problem you may get with the dilatation, they have these arrhythmia due to the re-entry, they can get atrial fibrillation. So with atrial fibrillation, what you get actually, some of these can actually separate as an emboli, can go other places. So two things always remember, every time you have these dilatation of the atrium, for any reason, okay, can be a problem with the left ventricle hypertrophy, or can be a problem with the mitral valve stenosis. Dilatation equal, then you can have mural thrombus in the atrium, and then you can have atrial fibrillation with emboli. Another problem with this is, remember, every time you have a problem like this, when you have a mitral stenosis like this, is a problem is the filling that left ventricle because blood cannot pass through this. So during this time, actually that left atrial kick that happen at the end of the diastole is very important. In normal people, that's not very important. But in these people, it's very important. With atrial fibrillation, you lose that. So this is one of the problem again with the atrial fibrillation. You lose that, end of the diastole atrial contraction or atrial kick, and that's actually make the problem, worse because actually no blood can go to the ventricle. So you lose some of the blood goes to the ventricle through that. Okay, this is some of the changes you may see with rheumatic heart disease. So this is after 20 years, you can see all of these are fibrotic, they're very, very thick. And when you look at actually here, this shows the aorta now. You can see this is fusion. This is very important. So contrast with the calcific degeneration. Over there, you didn't have any problem with the edge of those valve, the area that closed. But here you have a problem. You already have this fusion of commissure, you have this abnormality of thickening on the edge of the valve. And this is actually case shows both mitral and aortic stenosis. So you can appreciate actually here, you can have the aortic stenosis here, you have a mitral stenosis, and you can see both. Left ventricle is hypertrophic here, and then atrium is very, very dilated too. And you can appreciate actually right side is also kind of dilated, and that makes sense because if you have this pressure build up, can go to the lung, and later in the lung can involve the right heart. You all know about the cor pulmonale, so this is actually already kind of very advanced. And that's what you see in the lung, so that makes sense. Every time the pressure build up, is because of the left ventricular problem, left ventricular hypertrophy, then goes to the atrium and goes to the lung, or mitral stenosis starts with the left atrium and goes to the lung. So you're gonna have these passive congestion, chronic passive congestion in lung. You already know all these heart failure cells, which is the hemosidellated macrophages. Now, a little bit about the infective endocarditis. Now, we know in this patient, every time you have this abnormal hemodynamic around the valve, that's actually predispose the patient to develop infective endocarditis. As a matter of fact, there is a 3 risk factor for infective endocarditis. One is abnormal flow. Abnormal flow can be due to the shunt, can be due to the bioprosthetic or mechanical valve, can be due to the already damaged valve due to the rheumatic fever, like our case. That's one actual risk factor. The second risk factor is bacteremia. So bacteremia actually can be a sepsis, can be an infection, or somebody actually use IV drug abuser, so it actually produce bacteremia. You know, bacteria can go to the blood. So that's second. The third risk factor is immunosuppression. So you don't need to have all 3, okay? For example, somebody is IV drug abuser that usually these are associated with the tricuspid valve vegetation, infective endocarditis, and that makes sense because it's through the IV goes to the right side. These individuals, they don't have any problem or previous problem on the valve. Valve is okay, but they develop this infective endocarditis because the bacteria is very, very virulent. Staph, Pseudomonas, those gram-negative, they just go directly and damage the valve. They don't need the valve that's already damaged. But certain other bacteria, for example, those bacteria you can see in the mouth, they're not very virulent. You know, strep, mitis, those anaerobe, and that's actually those that usually attack the valve that's already damaged or any area that's hemodynamically abnormal. And that's usually they ask you in the exam. So they always love to ask you about these dentists. Some person has some problem, goes to the dentist, and they don't get these prophylactic antibiotic, and they develop these, you know, infective endocarditis. That's usually the subacute. So just understand there are different, you know, situations that make it an infective endocarditis. This one, you're familiar with this because you saw that in the first unit. This one, they always ask you, what's a complication of this? Every time we talk about complication of infective endocarditis, think about it. What is infective endocarditis? Infective endocarditis is a vegetation, is a clot that is infected, means have a neutrophil and has a lots of bacteria. So it can have damage, it can damage the valve or tissue just right there because of a neutrophil releasing enzyme, bacteria damage the tissue. So it can produce abscess, can produce rupture of those chordae tendineae or rupture or destruction of that valve. Just right there, right there, okay? Or if some of it actually separate as an emboli, can go somewhere else, and that not only produce infarction, also produce abscess because the bacteria goes somewhere else with the neutrophil, and they can damage the tissue. In addition of infarction or occlusion of the vessels, they can produce abscess. Like this one, they always ask you, where is this gonna go? This is in the tricuspid, so it's gonna go to lung, so it's gonna produce abscess and infarction in the lung. So, you know, very important to know the concept of this vegetation. It's really a clot which is infected. So when you look at actually these, as I said, this is actually mitral valve, and you can see this vegetation in both sides. You see the vegetation here, and then you can see some in the atrial side, and some actually involve the ventricle. So not only the vegetation attached to the valve, and that vegetation, as I said, we're going to look at the picture, but also can damage the valve, and then they're all going to be damaged to the ventricle or even atrium. So here actually you can see these are inflammation, neutrophil, and there sometimes they can produce a ring abscess. Now this is a composition of that vegetation. It's an infected thrombus, have a fibrin, have a red blood cells, and in addition have a neutrophil and bacteria. So let may ask you about, definitely, they're gonna ask you about this. This is the situation, actually, these are the type of the vegetation that you may see that are not actually infected. These don't have a bacterial neutrophil. They call it non-infective, endocarditis, thrombotic endocarditis. This is usually the way they ask you. They ask you what kind of situation these happen in, what patient. They usually chronically ill patient. The patient have a very, very severe chronic disease, malignancy. In malignancy, they have these hypercoagulation, hypercoagulable state. So the problem with this, they don't damage the valve actually in the area that they are there because they don't have a neutrophil, but they can separate as an emboli, so can produce the same problem. So here you can see in aorta, that can be separate and actually goes as a short emboli, can produce infarction in the brain or anywhere in the body. So the lab, and this is another example of these non-infective, non-bacterial thrombotic endocarditis. So you can see here, so they are usually don't have any bacteria, so don't damage the valve. You see the valve is a very, very nice, shiny, smooth. There's no damage, but they can separate and produce problem. The last one is something called Lippmann socks that can be seen in the lupus that can involve the both sides of the valve, and those are also can embolize and can actually go other places and produce problems. So next case, actually, we're going to talk about the hypertension. Oh, sorry, let me go.
The non-bacterial thrombotic endocarditis, does that have a, you mentioned that bacterial from like IVA will have a preference for tricuspid. Is there a preference for a particular valve and non-bacterial?
No, you can actually see it most of the time it's the left side, but no. Remember another thing about tricuspid, if somebody is an IV drug abuser, okay, they're gonna get actually endocarditis also in the left side. As a matter of fact, if you look at it, the more common you get it in the left side. So what the opposite of that is not right. So in a sense, if you have somebody actually, if you see a vegetation in tricuspid, definitely that person is one of the most common causes of IV drug abuser. But if somebody is an IV drug abuser, actually they get the vegetation in the other side too. It's sometimes more common, okay? So next case is the case of the hypertension. Think about the two type of hypertension. Essential hypertension, that's the most common type. 90% of hypertension are essential hypertension, and the 10% is a secondary hypertension. Every time you want to make a diagnosis of essential hypertension, you need to rule out secondary causes of hypertension. Who get essential hypertension? This is older individual, usually obese, have a diabetes, as related diet, related to there are some genetic predisposition. So all of these is important. You always consider every time you have somebody older comes with the hypertension, is the longest standing, this is probably essential, but you want to rule out the secondary, as I said. Two organs you always look for the rule out the secondary hypertension. One is the kidney, okay? Many kidney disease produce a hypertension. Glomerulonephritis, pyelonephritis, these are chronic pyelonephritis, chronic glomerulonephritis, end-stage kidney disease, polycystic kidney, they're all actually end-stage kidney disease produce hypertension. Now, another important point is hypertension can damage kidney, so it's kind of vicious cycle. If you have a hypertension, you have a damaged kidney. If you have primary disease of kidney, produce hypertension. They always ask you about the other very unusual kind of rare causes of hypertension. If, for example, you see hypertension in young female, you always think about some other causes. For example, this renal artery, fibrous dysplasia, muscular dysplasia, that's one cause. The young female, again, think about the drug, oral contraceptive actually produce hypertension. Same way, young male and young female for hypertension, think about the cocaine. If you think about hypertension in young age, rule out coarctation of aorta, that's actually is the way they present with hypertension upper extremity. So there are causes of hypertension that may ask you to speak familial. Now, another organ is very important for secondary hypertension is adrenal. Disease of adrenal actually produce hypertension.